Okay, good morning, everybody. Welcome to Internal Medicine Grand Rounds, virtual style. We have a really interesting discussion today, presentation, and we have four excellent presenters. I'm happy to introduce them. We're going to be talking about what 2020 taught us about addressing racism in medicine, and I can't think of a more topical subject right now for what's going on in the world and the country. So today our speakers are going to be Dr. Natalya Maharaj is an internal medicine peds hospitalist who spent time between Franklin and Children's Hospital. She's the faculty advisor for the Pediatric Academic Half-Day Health Equity and Anti-Racism curriculum. Dr. Yesenia Greeff is an adult GI doc, an assistant professor of medicine, and the assistant program director for the internal medicine program. She co-leads the social justice track for the medicine residents. Dr. Kathryn Jobbins is an assistant professor in medicine and is also the associate program director for the internal medicine residency. She's an academic hospitalist and also a PCP at High Street Health Center, and she leads the resident self-reflection and wellness curriculum and social justice working group across medicine, peds, and med peds. And last but certainly not least is Dr. Sharon Wretzel, who's the program director for the med peds residency, and is a primary care provider at Mason Square. And she, along with Dr. Jobbins, has presented nationally on addressing racism within medical education and is also an active member of the Social Justice Working Group and the co-founder of the Be the Change Reading Group at Bay State Medical Center. I think we'll have a very interesting talk from some excellent speakers. Take it away.
So thank you so much for that wonderful introduction. And so on behalf of Dr. Maharaj, Dr. Greeff, Dr. Jobbins, and myself, we're really excited to spend the next hour with you all talking about the other pandemic of racism that's occurred for longer than the past 14 months of COVID, and what the past 14 months have taught us about how to address racism within medicine, and specifically within medical education, with the hopes that by the lessons that we've learned over the past 14 months, we can help you who might be starting to do this work or thinking about starting to do this work or continuing to do this work in your own clinical spheres and in your own areas of work throughout Bay State. So before we get started, none of the four of us have any financial disclosures that are relevant to the talk that we're about to give you today. But more importantly, none of the presenters today self-identify as being from traditionally underrepresented in medicine backgrounds. It's also important to the four of us that you recognize that while some of us don't have lived experiences of understanding what it means to be on the receiving end of racial trauma or racism, that the work that we're about to present today is informed by and includes the work and the lived experiences of our Black and Latinx and Indigenous residents, faculty, and staff members. And that this work can't be done if it's just about my particular viewpoint as a white person. Although it is all of our responsibilities, regardless of how we identify, to address racism within medicine and dismantle it from its very core. So how are we going to tackle 400 years of history in only an hour, right? Like, that's a huge ask. So we've distilled this down into 3 different goals and objectives to help focus what we're about to talk about today. The first thing that we're going to talk about is the importance and the urgency of addressing racism within medicine and talking about not just healthcare outcomes, but also how we can better support all of our colleagues and all of our faculty and residents. We will then start to talk about how we began to create change and acted to address racism within our work, even while it felt overwhelming, with the hopes that the skills that we've gained and will impart to you today can help you think about how to begin to create change in your own clinical work, and then how to sustain the change, even if you're currently doing the work yourself. It's important that we all have shared language about what we're going to discuss. So let me take 2 seconds and step aside and just briefly describe some of the definitions of the words that we are about to use today in this conversation. So bias is a prejudice or thought in favor or support of one group compared with another. And we oftentimes talk about bias and implicit bias in the same breath. And so implicit bias is that bias or that attitude towards people, and you might not even know it. It will be an unconscious prejudice and an unconscious attitude towards or against a group of people. We'll talk more about implicit bias a little later on in this conversation. Discrimination is a prejudiced action that the act or the practice of discriminating categorically against a group of people, slightly different from bias, where bias is really the thought process around thinking about in-groups versus out-groups, and discrimination is the act on that bias. And then there's racism. And oftentimes, these three words, bias and discrimination and racism, are used interchangeably, although they're very different. Racism is specifically the belief that racial differences produce an inherent superiority of a particular race, leading to the systematic oppression of one group to the social, political, and economic advantages of another group. That's very different from bias or discrimination. We'll talk also about microaggressions and why this term is also fraught, but microaggressions is a comment or an action that subtly or maybe even unconsciously targets another person because of a particular identifying characteristic. And then underrepresented in medicine, we've already used that term. So what I mean when I use that term and what we will use that term for the rest of the talk today is to talk about people who self-identify as Black, Latinx, or Indigenous and are actively working within medicine as a provider, as a physician, an advanced practitioner, or a midwife. So I'm going to turn over the conversation to Dr. Maharaj and Dr. Jobbins.
So to begin, Dr. Jobbins and I will be reviewing the events of April through June 2020 that were the catalyst for the conversations and actions that we'll discuss throughout the talk. Next slide. Over the course of the past year, the CDC, ACP, AMA, AAP, along with other professional organizations, have recognized racism as a public health crisis. Next slide. These declarations have occurred simultaneously with the COVID-19 pandemic, which has highlighted that patients of color are disproportionately bearing the burden of the morbidity and mortality associated with COVID-19. This was first recognized as early as April of 2020, but since then, the disparate outcomes have persisted. As you can see, Indigenous, Black, and Pacific Islanders have the highest overall death rates due to COVID-19 in the United States. Next slide. The CDC has also identified that Indigenous, Latinx, and Black patients are disproportionately infected, hospitalized, and killed by COVID-19. And why is that happening? The CDC has also recognized that it's increasingly clear that race and ethnicity are proxies for underlying social, political, and economic structures that put people of color at higher risk for contracting COVID-19. In May of 2020, we all heard George Floyd's plea, "Please, I can't breathe." As we consider the impacts of COVID-19 on communities of color, while we're simultaneously confronting the realities of police brutality, it was important that we recognize that health and well-being of people of color is being stifled by structural and institutional racism. Medicine and medical education is not immune to structural racism, but as this passage states, the choice before the healthcare system now is to show, not tell, that Black lives matter. I'm going to pass things over to Dr. Jobbins, who will offer some more insight into structural racism within our field.
Thank you, Dr. Maharaj. So what we're going to kind of shift to focus on now is racism in the workplace. And a recent article that was published in Family Medicine showed that physicians of color are likely to experience significant racism while providing healthcare in the actual workplace. And they feel unsupported by their institutions when this occurs. Some common themes that came up in this article were exclusion. To quote, "I was treated differently compared to my non-Black counterparts and overlooked for leadership positions." Assumptions was another theme. I was denied away rotations as a medical student with a foreign sounding name from a foreign medical school. Rotations that were eventually agreed upon only once they realized I graduated from an undergrad from an aforementioned institution. Makes me think that when I applied to residencies, did my name and my medical school handicap my application due to internal biases of the residency program? Or even microaggressions came up. Numerous microaggressions occurred in the workplace without response from my institution. No persons of color were in higher positions, institutions are not fostering an environment of community. So what does this mean? When does this start? Next slide, Sharon, please. So actually, when you look at the data from the AAMC from 2015, you can see this actually starts very, very early on. That Black African-American applicants have a lower medical school acceptance rate than those of their peers. And actually, matriculation in 2015 was 6% for Black or African-Americans and 5% for Hispanic or Latinx. Now, you might think, okay, that was 6 years ago, a lot has changed. Actually, not much has. When you look at the data of the 22,000 students who graduated in medical school in 2020, only 8% were Black and 7% were Hispanic. The numbers are not shifting despite a large amount of efforts that's being done. Next slide, Sharon. And so thinking about matriculations from medical school, this pie graph shows you what the data looked like in 2015. Predominantly, it is white males who are graduating. We've actually shifted the number now, and so actually 50% of women make up the composition of all medical student graduates. However, from a diversity perspective in terms of ethnicity or nationality or heritage, it hasn't changed much. We've only moved the needle very slightly. Now, let's say, what does this look like for faculty members? Let's go to the next slide, Sharon. When you briefly look at this graph from 2015, you might see these green and teal bars and think there's not that much difference. However, medical student faculty members are predominantly white, 63.9%, and male, 58.6%. This becomes even larger as you go up the academic ranks. When you look at associate professors and professors, this is even more drastic. Now, the numbers I want you to understand here are over here on the sidebar. They're very small, but what they represent is the raw data. And I want you to understand, although this looks evenly distributed around the ethnicities, it's not. Only 3% of the 160% or 169,000 faculty members were Black. 2.2 were Hispanic and 14% were Asian. You start looking at the younger cohorts from 2020, and things are a little bit better in terms of the diversity, and women actually outnumbered men in most racial and ethnic groups. However, there is still a much larger predominance of white males who are in this diverse group. Next slide, Chair. And I wanted to highlight about what it looks like to be a woman in medicine compared to those who are men. So full-time faculty, only 39% are females. And if you look at the number of professors who are actually women, the numbers are very, very small. This gets even worse as you look at those who have different ethnic backgrounds. Only 4% of full-time faculty are Black, Hispanic, or Native American or Pacific Islanders. Next slide. So I'd like to pose these questions to you all to think about as we move forward. What does race-based medicine look like in medical education? Where is racism in medical education? How do we change race-based medicine as we implement new curricula moving forward from here?
Thanks, Dr. Jobbins. So as physicians, one of our critical roles is to be able to recognize, confront, and address health inequities. But as we consider our approaches to medical education, we have to recognize that much of our training has been race-based. We have consistently taught, and we've been taught, what has been termed race-based medicine. What does that mean? It means that we operationalize race as a biological concept. As a result, we frame race as an essential component of epidemiology, risk, diagnosis, treatment, and we characterize health disparities as due to inherent differences in Black and brown bodies. But genetic literature is pretty clear on this, and race is not a robust biologic category. So continuing to frame health disparities as related to race inevitably leads to perpetuating racial health inequities. As Dorothy Roberts, a renowned scholar of race, gender, and law, has said, she said this more eloquently than I can. So I quote, "The operationalization of race in medical practice without proper grounding in social political context perpetuates bias among medical students. These biases manifest as both irreducible, personal, and implicit biases, but also as ignorance of wider structural and systemic racism, which produce profound inequities in health between whites and minorities, ultimately contributing to disparities in patient outcomes." Next slide. We obviously can't stop talking about race and racial health inequities, However, if we adopt a race-conscious approach, where our initial foundation is recognizing that race is defined as a social and power construct, we can then examine the effects of structural racism in our basic science and clinical research, teach our learners the consequences of those effects, and adopt new clinical practices that ensure that we are addressing the structural barriers that racism defines, and ultimately we can reduce racial health inequities. Next slide. A classic example of switching from a race-based to a race-conscious approach is changing the lens with which we view estimation of EGFR. So with a race-based approach, estimation of EGFR in Black patients is generally higher based on the presumption of biological difference in Black patients. This ultimately leads to potential harmful effects of higher drug dosing, later transplant listing, later access to CKD care, and later initiation of dialysis. With a race-conscious approach of eliminating race-based calculations of EGFR, there is more equitable distribution of healthcare resources and potential for decreased harm in patients of color. As you consider this, I'm going to pass things back over to Dr. Jobbins.
So early on in April, when the events that occurred, a group of residents came together and decided they wanted to create a call to action. They wanted to do more, they wanted to be a part of the change, and they created the Be the Change working group. I'd like to read part of their call to action for you now so you can understand where they were coming from and where we are now. As a resident, we deeply understand the pivotal role we play in our patients' lives and the meaningful impact we can have if we fully embrace our potential patient advocates. To achieve health equity, we must dismantle racism from its core. This will involve actions at many levels, but the starting point for us is honest and open dialogue, acknowledging and learning from the past in an effort to foster reconciliation and positive change. We invite you on this journey to join the Social Justice Working Group. Together, we can bring about the change we seek. And now I'm going to turn it over to Dr. Greeff and Dr. Wretzel.
Thanks, Katie. So Dr. Maharaj and Dr. Jobbins have just walked us through an introduction to what we hope you're all starting to get the sense is really just the tip of an enormous iceberg. And so if you're feeling a little bit overwhelmed by all of this, you're not alone. We definitely were in the beginning of our journey as well. To be honest, some days we're still overwhelmed, but we knew we had to do something to start chipping away at this and not let the overwhelming scale of it just paralyze us. Next slide, please. So we started with small steps that felt within our reach, even though we were still thinking big. And so one of the very first examples of this were the Be the Change working group that Dr. Jobbins just referred to, started by her and a small group of residents. This is now expanded to include more people across multiple residencies, students, faculty, and residents. And this was small and it was simple, but it opened up a space to start to understand who else was out there in our training programs that wanted to talk about this. What ideas people had about how we could all learn more and how we could move toward making meaningful and sustainable change here at Bay State for our colleagues, for our trainees, and also for our patients. And one of the very first products of these meetings were the Be the Change reading group, which is still meeting monthly. And this created a safe space dedicated for, again, students, residents, and faculty all together to learn about anti-racism and to discuss difficult topics. So these monthly meetings, we focus on a selected op-ed or a podcast or journal article, and we come together and discuss them for an hour, one evening a month. Some prior themes that we've explored have been things like racism in end-of-life care or bias in medical education, for example. But throughout this journey that we're going to be describing to you, you're going to see a pattern arise. As we jumped in and tried to do more, we learned that there were more gaps in our skill set that we needed to address. Next slide. So what we learned quickly was that we needed to continually hold our doors open and empower others to join us when they were ready, because not everyone was ready at the same moment. And so by continually re-extending our invitations to a broad audience, we were able to warmly accept those people when they came around. We also had to be able to navigate conversations at work that were sometimes challenging. And some of these conversations for many of us were even taking place at home, explaining to people why we were doing what we were doing and why it was so important. And along those same lines, we also had to learn to recognize when there was a mind that we were encountering that we might not change right now and how to be efficient with our energies. Next slide. So as we were working on those skills, one of the first things that we did starting June of 2020 was to start making some tangible curricular additions. And the very first of these was the addition of a social justice track to our academic half day. And for those of you who aren't familiar with our academic half day tracks, traditionally there have been 4: hospital medicine, humanities, and research and quality improvement. And the residents select one of these to follow through the academic year. They meet once a month. For the social justice track that we added as the 5th track in July of 2020, the residents come together on that monthly meeting. We discuss various social justice issues or racism in medicine issues. And there are also a couple of smaller longitudinal projects that the residents are engaged in. The pediatric residency has also started a parallel anti-racism curriculum in their academic half day, led by Dr. Maharaj and some of her colleagues. And these are just a few of the changes that we made very early on. So as we grew and started to recognize additional areas where we wanted to make these changes, we then were able to return every 2 weeks to the working group and coordinate our efforts, make sure we weren't duplicating efforts, making sure our strategies weren't conflicting, and also to pool our resources and keep inviting in new people. Next slide. So over the following months, we were then able to add more layers to our curriculum. So for example, we added social justice insight sessions to our academic half days. These were small case-based breakout rooms that the residents would go into and discuss. For example, the very first of these was a discussion about race-based antihypertensive prescribing guidelines and understanding where those come from and how to think critically about them as well. There was also an academic half-day session created by some of the residents for Black History Month on Black excellence. And these were some of the additions that were really by our design. These were intentional. But then as we went on in time, the residents themselves have actually started to integrate social justice topics into their journal club presentations, into their morning report presentations, really on their own without any prompting from us. But again, we were stretching our efforts and really started to see more skills that we needed to build on. And what was really becoming clear to us this time around was the fact that as much as we wanted to get all these things right the first time, and that was important to us, sometimes, or even sometimes a lot of the time, we were going to mess up the first time around. And we had to learn how to grow from those mistakes and move on and do better the next time. Next slide. So the name of that skill was really getting comfortable with being uncomfortable and learning that that pit in our stomachs when we were faced with something so unfamiliar wasn't a sign to turn around and give up, but to keep moving forward. And this is a feeling we think a lot of you will be able to relate to. When there was so much unknown about COVID in the beginning of the pandemic, we all just had to keep moving forward in the hospital. And we hope you'll all think back about how you dealt with that discomfort, because that's a skill we had to draw on during this process as well, and we continue to draw on. So now I'll hand it back to Dr. Wretzel.
Thank you so much, Dr. Greeff. There's no more discomfort than recognizing that you're engaging in thoughts or behaviors or patterns that you really wish you would not engage in. And I think one of the more difficult pieces for all of us is recognizing the unconscious or the implicit bias that we all have, and that we all engage in even when we don't want to. And that has been really difficult. And so for those of you who have not yet taken an implicit association test, it may be interesting for you to think about taking one to see whether or not you yourself also have implicit bias. But spoiler alert, all of us do. We are all humans. And the best neuroscience has to offer in this moment demonstrates that as we are bringing information into our brains to sort through all the information that we get during every second of every day, we are making snap judgments all the time of in-group, out-group, threat, not threat, whether or not this is a place that I feel comfortable or not comfortable. And so implicit bias does live in all of us. The 2016 study that showed that actually implicit bias is existing within physicians and within advanced practitioners at the same degree and the same level as the general public shows that we're not immune. So what to do when we have thoughts or behaviors or patterns that we would prefer not to have, that we know are impacting our medical decisions, that we know are impacting our ability to create diverse spaces filled with equity and filled with inclusion. So we recognized that this was a huge blindside for us, especially as we were going into the residency recruitment season, and we really wanted to address this. So in September of 2020, a group of 6 of us, including myself and Dr. Greeff and Dr. Jobbins, and a handful of others, created a 6-hour-long series of talks over the course of 2 weeks that we gave to every single person in the medicine program leadership and the MedPeds program leadership and anybody else who was interviewing for us on implicit bias. We covered topics such as recognizing bias, the harm that bias does, how to recognize bias when it happens, how to stop it in its tracks, how to mitigate bias, and how to call each other in when we were recognizing that other people were engaging in biased thought. And I think that this went a long way to start a new recruitment process that has really led to increasing diversity within our residency program. When we increase diversity and we have a residency program that mirrors the community that we have the honor of being able to serve, we know that our community members are getting fantastic healthcare. When we have a residency that is fully diverse, we know that our residency is moving forward because we have diverse voices that can be heard and can be listened to and can add to our process. And so I invite you to think not just about residency recruitment or fellowship recruitment, but also what recruitment looks like in all of your clinical spheres and all of the work that you do, and whether or not some of the strategies that we employ that I'm about to discuss with you can also be used as you're thinking about hiring faculty members or staff members in your own places. So the first thing that we did is not just recognize areas of bias that we had when I was looking at an application, when we were looking at applications, but recognizing areas of bias within an application. So letters of recommendation are filled with bias. For us, that also means dean's letters and evaluations that people are getting within medical school. People have access to different extracurricular activities. They have access to different things that will help support their application, and not everybody has equal access to all the abilities to be able to provide to get to extracurricular activities that might support their application. So thinking about areas within an application, areas within a CV that you might be reviewing. And then we took a review of every single application within pediatrics and MedPeds. For all 3 residency programs, these were blinded reviews, so we did not see anybody's photographs, we did not see anybody's identified race, gender, or ethnicity. And we committed to a holistic review of these applications to be able to take a look at the entirety of an application and not just one metric to determine whether or not somebody was going to get an interview. And because of this, and I'm happy to share this metric that we used in MedPeds with anybody who'd be interested, we were able to take a look at people who had life experiences that were going to add to our residency, that were going to be able to show that they were really like fantastic members of the community that would really add to our residency voices. And so I'm talking now about culture fit versus culture add. One of the parts of the conversation that we had early on in September of 2020 was looking at a talk that was given by our former diversity and inclusion officer, Yemisi Ellerin-Toller-Coates, who talked about this concept. When you have a culture fit, you are looking for somebody who fits with your culture, who looks just like you, who acts just like the group that you are part of. When you talk about a culture add, you're talking about the values that are really important to your group and how the person you're about to interview, how the person you're about to add to this group can add to the values of the group that you are a part of. And I think that that subtle distinction is actually quite a large one. And I think it's really important to consider as you are starting to hire, as we start to look at more and more residency applications over the next few years, how these people are adding to our residency program rather than just fitting in. And in medicine and in pediatrics, there had been for years multiple interviewers. MedPeds adopted this year as well, which meant that we had interviewers that weren't just part of program leadership, adding to a diverse voice and a diverse perspective for all of the applicants that came through. And I'm happy to say that across all 3 residency programs, we were able to really recruit a fantastically diverse incoming intern class. And I'm really excited to see where this leads in the next few years. So I'm going to pivot a little bit because part of the work that we started to do was recognizing that we could do this work, but if we are doing this work in a vacuum, then it will be hard to sustain the work that we are about to engage in, and the work that is really important to continue going on. And so somewhere around September and October of last year, we recognized that we really needed to think about how what we were doing aligned ourselves with the mission of Bay State Health. So this is Bay State platform. Most of us have seen it. If you haven't seen it, in the center here, it talks about the mission of Bay State Health and the reason why Bay State exists. It's to improve the health of the people in our communities every day with quality and compassion. Now, I can read this mission statement and see very clearly where anti-racist work and where working within a community and where recognizing the community's needs and meeting a community where they're at can really be part of this mission statement. But I can also see it within the values of respect and integrity, within the core competencies of valuing differences and learning how to value each other's differences, and how we work together in our culture and how do we lift up our talents and unleash our potential. So I can see how our work has been aligned with Bay State Health, but don't just take my word for it. This is Dr. Kerouac's statement. He has this on our Bay State Health website. At Bay State Health, he says, we're on a journey to examine our policies and our practices and our behaviors, similar to how we've been doing this in our residency programs, and to hardwire sustainable change towards inclusivity and equity, just like we are working towards in our social justice working group, in our Be the Change reading group, and throughout our curricula in all 3 residency programs. Because doing so is not only the right thing to do, it's the advantage that compels people to come to work here, to come to our residency programs for training, to hopefully stay on as faculty, and to receive the care and services we deliver. This makes us a better organization. It's critical to the fulfillment of our mission to improve the health in all the communities that we serve, including the communities that our residents have the pleasure and honor of being able to serve in. So in October of 2020, the work that we did actually won a Presidential Excellence Award at Bay State. We were not able to do this in person, and so we have this poor screenshot of the award that we won. But we won the Distinguished Performer Experience Category Award to the work that we have been doing thus far in up till October. And you'll see there's actually so much more work that we have done and so much more work yet to be done. I'm really excited to see where this group goes. We also aligned ourselves within our communities, and we started working with Anna Marie Golden, who is the Community Outreach Officer at Bay State, and Dr. Frank Robinson. And we looked at the Community Health Needs Assessment from 2019, and we'll be looking at the one from 2020 to see what it is that our community needs and what they're asking for, because this work is really important to us, but it's really important that our communities are able to get the healthcare that they need and deserve. To that end, some of the early projects that we've been engaged in is aligning ourselves with the Vote ER project. The Vote ER is a project out of Massachusetts General Hospital in Boston that was started in January of 2020 when a group of ER physicians said, we have a lot of people who are sitting in our ER waiting room who are waiting for care, and that would be a great time to be able to register them to vote. Because when people are registered to vote and are able to vote and are empowered to vote, they can vote for the changes that they need to see in their own communities. They can vote for measures that bring about better healthcare and better housing and better educational opportunities. And so the Vote ER project, and you probably saw a number of us walking around with these badges, with these tags in our badges, and some of us still have them, where you can have a QR code and a patient can use their phone to shoot at the QR code, and in either Spanish or in English, can register to vote right there on their phone in the office with you. And so we had lots of different providers throughout all 3 residency programs having these badges. And we also had people sitting in the waiting rooms of our community health centers, also helping people register to vote. And what was interesting to me as a provider was being able to have this conversation with my patients in the point of care. I was talking to them about their diabetes, and I was talking to them about why it was important to have politicians that represented their needs to be able to address their health care better. We also were engaged in the nationwide kneel out a week after George Floyd's death with White Coats for Black Lives here at the hospital and also at all 3 community health centers. And I think what this did very early on for us is recognize the vast group of people from across the institution who are really interested in doing this work, but it also at the community health centers allowed us to show for our community how deeply we cared about this. We are also now in the process of growing the work that we're doing in our community. So very recently, as recently as 3 weeks ago, some of the MedPeds residents have started working with a local radio show called The Gap Closer to talk to kids about their healthcare issues and questions. And we've had people be able to attend the past 3 weeks of this radio show and be broadcast throughout Springfield. We also have a nascent group of individuals who are starting to talk to local churches in conjunction with the Black Employees Connecting Group, BRG, here at Bay State, to talk about questions that they have regarding COVID-19 and regarding the vaccine. And so it's really interesting to me to see how we're diving into our communities and doing the work that our communities need. We are also aligning ourselves nationally. So it's important to align yourselves with the work that we're doing here at Bay State and also what our communities need. But it's also important to know that we're not in a void. So again, we're aligned with Vote ER and White Coats for Black Lives, and we have been using the White Coats for Black Lives report cards to look at the curricula that we have, both in MedPeds and medicine, to think about where we could add anti-racist curricula and how we could better understand and dismantle racism within our medical education spheres. We also are aligned with our parent program, national program. So the Alliance for Academic Internal Medicine houses both the Association for Program Directors of Internal Medicine and the MedPeds Program Directors Association, as well as the Association for Pediatric Program Directors. All three of these programs, all three of these national groups have put out statements about anti-racism within medical education. The Association for Pediatric Program Directors has had a vibrant and fantastic workshop series about how to incorporate anti-racism and address racism within medicine in a pediatric residency program. The MedPeds Program Directors Association now has a point-by-point guideline for how a residency program can incorporate anti-racism within their residency program and has a whole list of literature to boot. The Association Program Directors in Internal Medicine just had their national meeting. And at that national meeting, there were a number of talks on anti-racism, including a talk that Dr. Jobbins and myself and Dr. Shaban, Dr. Belforti, and Dr. Churchill gave on incorporating anti-racism within a residency program. So it's wonderful to be able to know that we are aligned with all of these groups because that helps with sustainability. But as we all know, we're a little exhausted. We've gone through a lot in the past 14 months. We've gone through a lot addressing a COVID pandemic, and we're going through a lot trying to address racial equity and justice. And so how do we continue this change? How do we create the new normal? How do we think about this work that gets to get done for many, many years going forward? And so I wanted to give this and share this imagery with you based on a conversation that I had earlier this year when times seemed bleak and the news cycles felt overwhelming, and I felt like, is the work that we're doing ever going to actually change anything? And the woman I was speaking to, her life's work is about creating change within communities, help communities that have been marginalized, create self-determination and create communities of safety and of justice. And she was talking to me about an image that she uses to help herself understand how to maintain momentum. She thinks about an ocean, and when storms happen, the ocean gets swirled and large, big waves of people join, or big waves join in the storm. And as the storm dies down, as the waves crash into the sands, some momentum gets lost, but there's still a lot of momentum left in the ocean. And as each wave comes into the ocean, as each crest of the wave gets larger, more and more people join as they see more and more injustice happening around them. And I think that this image of the oceans and the waves were really helpful, especially during some of the big times for me. And hopefully this image is helpful for you as you're thinking about either creating or sustaining change that you have already worked on within your clinical spheres. But there are barriers to change, and we've mentioned a lot of them already. We've talked already about being comfortable with being uncomfortable, and this is hard. It's hard for everybody. We all want to do this really well. It's hard for me to know that I fail a lot, and it's also hard for me to know that I'm going to make mistakes. But if I'm not making mistakes, I'm not actually doing the work that needs to get done. I need to be uncomfortable because this wasn't something that came easily. We need to create space, and this is hard given all of the hats that every single one of us wears. and all of the things that we need to do and all of the metrics that we need to meet, how do we also take time to create space to start small, to think small, or create space to grow the programs that we are already engaged in? How do we create time to be able to do this at work and maybe even beyond? As Dr. Greeff mentioned before, not everybody is ready for change, and that leads to uncomfortable times and uncomfortable conversations. This is hard to figure out, and so we will be ready to be uncomfortable to have some of these conversations. But it's also about being open to creating a welcoming environment for people who are ready for change, ready to learn more, ready to do more if they haven't started already. And this is a long road. As I mentioned before, this is 400 years of history that we are talking about. This is going on for a long time. It's going to take a very long time for us to see the change that we are hoping to create. But we've got momentum and we've got the abilities to do this. And we've got all of you who are interested in helping us make this change. And so I'm going to turn it over to Dr. Jobbins to talk about some of the areas that we are about to engage in over the coming years and ways that you can get engaged with the work that we are doing if that is something that you are interested in.
Thanks, Dr. Wretzel. So thinking about where we've gone, we have to start thinking about where we want to go. Microaggression training is one of the first areas that we're going to be tackling across medicine, med peds, and pediatrics. Our hope is that over time, this will not only be in our departments, but health system wide. A big thing to consider here is, what does that look like? What's important topics to talk about? We're going to be partnering with the Burst Academy to go through the restorative justice training to talk about what trauma actually can do to patients, to ourselves, and to our colleagues. And how do we actually find a place to feel that we can heal? We're opening the group, the Be the Change Social Justice Working Group, to all of the residencies here. If anyone is on this call and would like to be a part of it, please reach out to any of us who are speaking today, and we'll happily give you more information about any of the areas that we're working on. The hope with this is that this will become part of our culture, starting from day one when a trainee or a new faculty arrives here, to also encourage them to be a part of this culture and to perpetuate it. We're also working on how to learn to report racism. We have an SRS system that has this as part of it now. What does that look like? Who does that go to? Who's responsible for dealing with this? And if we see this happening, are we brave enough to say something in a way that brings someone in instead of excluding them? We're working more with the community engagement. What we realized when we reviewed the 2019 results with the ACO team is that many of our patients didn't care about the police brutality that we all thought they did. It's important, but not the most important thing. They were more concerned about their mental health of the young people in the community with the COVID pandemic. How can we partner more with our communities and do what they need, not what we think they need? So we're going to continue to examine that. And also looking at professional lapses about racism. Many people, like Sharon and Yesenia and Natalya have mentioned, have experienced this. How can we as a professional community foster that this is not okay and make a positive change? I recently got an email from a colleague and friend who works in one of our ERs about how they experienced racism growing up in the Midwest. And he was so grateful to see that there was a culture change happening here at Bay State and to keep up the good fight. So I leave you with some questions to think about. If not you, then who? If not now, then when? We encourage you all to be the change. Very grateful that you were able to be here today for our talk. We'll now take any questions, and thank you for being here. So it looks like there's a couple of questions in the chat that I can go ahead and look through. It says, when it was announced that our chief DEI officer was taking an opportunity elsewhere, it seemed that there is not a plan to recruit a new DEI officer. Is this true? One second, just jumped. Did I misunderstand the announcement? I believe that they are going to be recruiting. I just don't know when that is and what that looks like. I haven't heard otherwise. I know they're trying to be very thoughtful about doing it the right way. And then another one, does anyone else have any other comments about that?
Hi, this is Tanya Santos. I've heard that the plan is to absolutely recruit for that position.
Great, thank you so much, Tanya. The other one, someone made a comment, profound and data-informed presentation. We are the BH statistics for URM across the department, service lines, faculty, and staff. Oh, what are the, so it's interesting, the statistics across the URM department, service line, faculty, and staff. If you look at the data, actually in our residencies, it's very diverse. If you look at our faculty, it is not diverse at all. If you look across our staff, it's actually much more diverse than our physicians and advanced practitioners are. And as you get higher up in our leadership structure, we are not, unfortunately, a diverse institution. I know that we are actively working on improving that, and retention of faculty from underrepresented backgrounds, it has been a priority for the institution. How will you plan to measure the impact of your program? Thank you so much, Dr. Broder, for that great question. Sharon, do you want to answer that one, or do you want me to answer that one?
So that is a fantastic question. And I think that initially, as we jumped in, we just jumped in with both feet. We weren't thinking even about how we were measuring. And I'll be totally honest about that because the urgency and the need was so great. But now, as we are developing curricula that is really fantastic and dynamic, we really need to think more about how we are measuring what we are doing and whether or not we are actually having impact. So to that end, the new curricula that Dr. Jobbins was just discussing around microaggressions and how to be an active bystander in clinical settings in which microaggressions and racial trauma are occurring, will come along with a pre and post test. There is a large curricular working group that is already doing this work. The curriculum will be delivered over the course of the next year. And our hope is that we'll be able to see more comfort with addressing microaggressions within a clinical setting and more comfort with being an active bystander for people who are experiencing those microaggressions. And then Stephanie Hucker was talking about, the next question was doing what patients want as opposed to what we think they want. Is there a standard process at Bay State for engaging individuals we serve in these conversations? And so, yes, there is a community advisory board for all of the community health centers that is actively engaged in having members of the community help the community health centers know what it is that they would like to be able to address. There is also a large and vibrant community outreach group at Bay State. And Dr. Jobbins, you might want to talk a little bit here about the work that Anna Marie Golden is doing.
Yes, so Anna Marie Golden is a fantastic resource, and she partners with many community organizations. She actually sends a distribution to many people within the organization about community events that are going on, and they are distributed amongst a larger group within the health system. She has been partnering with the community to ensure that the efforts that Bay State is doing is in line with what the community efforts are as well, and how we as an institution can support those efforts, and also allows for us to participate, engage, and also be a part of those groups as well too. And she hopes to expand that further in the next couple of months as well.
Any other questions?
Sharon,
Go ahead.
I just wanted to jump back quickly to Sharon's answer about how we're trying to measure our outcomes, because that is just such a fantastic question and one we've been thinking a lot about. And so another question we've had is, how do we measure culture change? Because that is maybe impossible to measure, and we can only really go about it, from the side, basically. And so one thing that was very briefly mentioned, I think, by Dr. Jobbins was this new reporting system that I just want to go back to it since we have a moment and make sure everyone's aware of it, that our SRS system now includes insults or injury to patient or employee dignity. And this is a way to report any interaction that you have with another employee or a patient. And this includes things like microaggressions. And paradoxically, if we're able to shift the culture here at Bay State, but we're hoping that those reports will actually increase as people realize that they're not acceptable, as people become more comfortable speaking up. And so that is something that we're hoping to be able to examine more closely. So we do want to make sure that you're all aware that that exists.
Any more questions?
think I see one other question in the chat room here, which is fear of working in an echo chamber. Is there a relationship to community organizations for the same goal of anti-racism efforts and inclusions in this initiative? And so, yes, there are, and I'm happy to talk about it, but I think Dr. Jobbins and Dr. Maharaj have been nodding their heads, and I would like them to be able to answer this as well.
Dr. Maharaj, why don't you go?
Okay, so one of the goals, I think, once we started this initiative was that we were elevating community voices as well. We are working with Dr. Robinson and Marie Golden and the existing infrastructure that we have within Bay State to connect with the community and make sure that we're sort of working along the lines of building relationships with areas and organizations that have already built trust with the organization instead of duplicating efforts and confusing the community, essentially. So we're working on building that relationship with our existing partnerships, and we'll be making connections as we continue to develop curricular efforts throughout the organization as well.
Thank you. That was really great. What I really liked about, well, a lot of information, but that you guys are actually in action doing this as we speak. So not only do we learn about the background, but how you sort of took action and are in process right now and evolving, and you're thinking about how you're going to measure it, et cetera. So it's a really good example of putting something into action. So it was really informative and very timely. I want to thank all four of our speakers and our participants for the questions. Thank you.
Hi, guys. This is Tanya again. So I think to the question of measurement, one of the things that we're looking at in the Department of OB-GYN is our employee engagement surveys that I've been able to get access to, stratified by race and ethnicity. So that might be something to look at. I don't know if you have similar feedback or surveys of residents, but in OB, I'm trying to look at tools we already have and how we can use them rather than figuring out how to collect something else, because there are so many hoops to jump through and so many rules. And also it's additional work. And if we're trying to conserve our energy for the parts of this work that really need our personal attention, then those might be some shortcuts to look into. And I've also been able to get some patient satisfaction data stratified by race, language, and ethnicity. But as you probably know, it's messy. Hence the, other higher level efforts to look at how we collect data throughout the institution.
So, Tonya, I really appreciate that.
Yeah, I'd be happy to show you guys. We could have a meeting and I'd be happy to show you what I do have access to once I have time to process it a little bit more. So I got some data from Yesenia about the employee satisfaction. One of the biggest issues is that a lot of people don't answer the race question because they don't know what the information is going to be used for. So I think we have a system-wide issue where people don't understand how we're going to use the information, so they don't trust us with the information. So they give us the information, so we can't use the information. So I think a lot of what we need to do is build trust with our communities, both internal and external, with transparent explanations about why we want this information, and then actually use it and be transparent about it and let people see it, so that we build that trust. It's a chicken egg situation. So yeah, I'd be happy to meet with you guys and show you what I have for the employee engagement stuff, which I haven't really had much time to process yet, but also some of our patient satisfaction stuff.
That'll be awesome. Thank you so much. I also realized that there's a recent study that came out that showed how we collect all this data when we have to do our yearly surveys, Sharon. And I can send you guys the link for the article. It was in this SGIM MedEd update, and it talked about a lot of like the anti-racism efforts and how some organizations have no idea how to start, or that they have no initiative that they're going to start, which I found so mind-boggling for me too. So I think there is, like you said, Tanya, so much data out there, and it's just figuring out how to find it and then how to use it the way that doesn't add more work for us trying to figure out how to filter it all out.
Yeah, I've wondered about using the I forgot the name of the survey because it's been 2 years since I was a resident, but the annual survey that we send out, whether there was any way for us to use that data at all in terms of assessing resident attitudes as well.
So to my knowledge, that survey does not collect data on identification. It does collect data on professionalism and on witnessing or experiencing microaggressions, but it does not talk about who the person is. I think that would be hard to get at from a resident perspective. But yeah. Thank you all.
Guys, this was great.
Thanks, Tanya. All right, bye guys, great job.